This video begins with a brightly colored image featuring line drawings of heads of various shapes and sizes, and the text, Inclusive SciComm Symposium 2021, hashtag ISCS21. Thank you to our major sponsors for the Inclusive SciComm Symposium and for this keynote: Science Sandbox, an initiative of the Simons Foundation, the Burroughs Wellcome Fund, the Chan Zuckerberg Initiative and Silicon Valley Community Foundation, the Rita Allen Foundation, the Kavli Foundation. Thank you also to our contributing sponsors for the Inclusive SciComm Symposium: the University of Rhode Island Division of Research and Economic Development, the University of Rhode Island College of the Environment and Life Sciences, the University of Rhode Island Graduate School of Oceanography, the Monterey Bay Aquarium Research Institute, the Schmidt Ocean Institute, the American Association for the Advancement of Science Dialogue on Science, Ethics, and Religion, and the American Association for the Advancement of Science Center for Public Engagement with Science and Technology, the Union of Concerned Scientists, and the Association for Education in Journalism and Mass Communication Division on Communicating Science, Health, Environment, and Risk, and the University of Rhode Island Office of Community, Equity, and Diversity.
Hello, everyone. I'm Sunshine Menezes, Executive Director of Metcalf Institute at the University of Rhode Island. On behalf of all of us at URI, Metcalf Institute, and the 2021 Inclusive SciComm Symposium Planning Committee, it is my pleasure to welcome you to today's keynote. The University of Rhode Island, or URI, is located on the ancestral lands of the Narragansett and Eastern Niantic people. Their lands originally encompassed what is now the state of Rhode Island, Eastern Connecticut, and Southern Massachusetts. It is important to acknowledge that this land was stolen. For example, URI benefited from the forced removal of Indigenous ancestors from the land where our university now sits, and from the unjust cession and taking of land from other Indigenous peoples as part of the U.S. Land Grant College Act of 1862. These takings included land from the Kaw Nation that was sold to fund our institutional endowment. Before URI was founded, this same land was a farmstead that exploited enslaved African and Indigenous labor, and their bodies are still buried on our campus grounds. While our institution has far to go to meaningfully address this history of land grabbing, genocide, and racialized injustice, we have begun to take some action. The Tamaqua Museum, which has been promoting thoughtful dialogue about the history and present of the cultures and arts of Southern New England's Indigenous nations since 1958, will be breaking ground on a new site on the URI campus in 2022, and we are excited that the university committee will be encouraged to engage in broader conversations about our shared history and present via this collaboration. The university has also committed to provide Narragansett students with full tuition upon acceptance. We hope that these steps lead to additional concrete actions in the very near future. This symposium is a small part of the process of social and structural transformation these acknowledgements require. The Inclusive SciComm Symposium was launched in 2018 as a way to convene people originally across the United States who were doing science communication differently. Specifically, we invited speakers who were centering the values of inclusion, equity, and intersectionality in their work. They included museum exhibit designers, community organizers, journalists, teachers, researchers, funders, artists, and people who practice science communication in many other ways. In other words, we interpret science communication in its broadest sense. That first symposium met with such an incredible response that we decided to continue it, and this marks our third symposium. Our attendees this year are coming from nearly 40 countries. This has been an incredible opportunity for us to both build our networks and to learn and to unlearn together. We're grateful, as noted in the opening video, to the many generous sponsors of the 2021 Inclusive SciComm Symposium. Today, as part of the 2021 Symposium theme of building and supporting the inclusive SciComm community, we're thrilled to welcome our speaker, Jessica Malaty Rivera. To introduce Ms. Malaty Rivera, I am pleased to welcome Dr. Ana Maria Porras, a member of the planning committee for this year's symposium and an assistant professor of biomedical engineering at the University of Florida. Dr. Porras is herself a global leader in inclusive science communication. She crochets various single-celled organisms to spark interest in the microbial world, and she's been actively engaged in advocating for and participating in Spanish language science communication on social media and elsewhere. Dr. Porras also will moderate the discussion following today's keynote. Please note that this program is being recorded and we'll post the recording to Metcalf Institute's YouTube channel next week. Now, I'll turn the program over to Dr. Porras.
Thank you, Sunshine. Welcome, everyone. I am so happy to be here and so glad that you could join us. I am honored today to introduce our keynote speaker, Jessica Malaty Rivera, who is an infectious disease epidemiologist and science communicator. She earned her MS in emerging infectious diseases from Georgetown University School of Medicine and has dedicated the last 15 years of her career to disease surveillance research, public health policy, and vaccine advocacy. Her specialty is in translating complex scientific concepts into impactful, judgment-free, and accessible information for a diverse audience. She is currently the science communication lead for the COVID tracking project at The Atlantic, which you may have seen all throughout the last year, a research fellow at Boston Children's Hospital Innovation and Digital Health Accelerator, an infection preventionist for Netflix, and an expert contributor for NBC Bay Area and CNN. Jessica was recently named one of the world's 50 greatest leaders by Fortune magazine for her work on COVID-19 research and data communication. Between her day jobs and being a full-time mother to 2 little kids, she also dedicates several hours a week to promoting science literacy and debunking misinformation on social media. I personally first became acquainted with Jessica's work on Instagram last year, deep into the early days of the COVID-19 pandemic. You can remember what those days felt like. Her expertise and empathy helped resolve many of my doubts, as well as those of thousands of people. As a Latina who also doubles on vaccine work and who is also trying to engage with audiences on social media, Jessica has been both an inspiration and role model for me throughout the last year. Today, Jessica will share her approach to building trust of medical professionals amongst communities of color through the development of supportive and equitable relationships. I can't wait to hear what she is about to share with us today. If you have questions for Ms. Malaty Rivera, please post them in the comments or the chat during her talk. We'll do our best to get to as many questions as we can at the end. Take it away, Jessica.
Thank you so much for that incredibly warm welcome. I am so honored to be here. I want to start by recognizing the indigenous people who occupied this land before I was a resident here of San Francisco, the Ramaytush people of California, who were the original people on this land, and appreciate how we presented this start of the conversation in that somber recognition of indigenous people. I want to give a little bit of background about how I started as a science communicator, and then I'll walk you through some of the lessons and best practices we acquired at the COVID tracking project, and then give you some applications on how we can build and maintain trust as science communicators. So several years ago, as mentioned in my intro, I worked and studied at Georgetown University. And I was part of a project called Project Argus that was intended to track indicators and warnings of emerging biological threats, essentially trying to predict the next pandemic. We had a team of analysts who spoke about 50 languages, and we tracked this information using open source research. And our team actually identified the emergence of the 2009 H1N1 pandemic. We were essentially creating this system to forecast what could be possible threats. In that process, we were translating this information and making sure that anybody with any kind of expertise, whether it's in infectious diseases or whether it's just in biosecurity and surveillance, could understand what we were saying and make informed choices. So being able to quite literally translate from other languages and then translate the science became something I became very good at, and also something I became very passionate about, because for so many years, as somebody who spent most of my education focusing on understanding science, I found that a lot of people communicating that science didn't look like me, didn't have my background, and were not often speaking in a way that invited people into the scientific process. One of the most motivating quotes describing science communication by Sir Mark Walpert is that science isn't finished until it's communicated. For so long, as a member of academia, I would just see science kind of stuck behind the walls of laboratories, research groups, in papers that were very, very difficult to understand to the average person. And I found that to be very frustrating, because what it does is it continues to isolate people from the process. And I very much believe that science, and data in particular, belong to the people. They belong to the folks who they are trying to protect, inform, heal, and change as we continue to learn from the scientific process. So that work really shaped my career, especially as a woman of color, and becoming a trusted messenger was the inspiration for every single career decision I made since that time. Now, COVID-19, the pandemic, has been probably the most obvious example of what it means when you defund and you devalue public health. That work that I was a part of was funded by the US government, and over time was systematically defunded and brought in-house. That I look back with just brokenness, because I do think that what we were providing could have actually given us a very different starting point when COVID-19 emerged. And that brings me to the COVID tracking project. COVID tracking project started with a couple journalists who were just trying to find testing data at the Atlantic, and it was two guys and a spreadsheet. And after they realized that testing data wasn't in a uniform or single place, namely at the CDC's website, they decided to collect that data manually, and it turned into the COVID tracking project, which kind of functioned like the CDC in the absence of the CDC providing this kind of detailed, granular data from the states. Now, I came in pretty early on. I found out about the COVID tracking project on Twitter, and I DM'd Alexis Madrigal and told him about my background and said I would love to help. And I helped create the science communication team. You could theoretically say that everything in this space is science communication. There is data, we have to translate the data. There are charts and visualizations, we have to make sure that people can read them and interpret them correctly. And then there's actually the words, the analysis, the blog posts, the reports that we would write, that we needed to make sure anybody reading them, whether a scientist or a layperson, could understand what was going on. Now, if you've been in infectious diseases, you know that there's always two pathogens that you're tracking: the actual pathogen that is emerging and the information about it. That's what we call an infodemic, that is in tandem with a pandemic or an epidemic. Now, an infodemic doesn't always mean misinformation and disinformation. It's just an overabundance of information. And in the context of an emerging pandemic, there is a lot of emotional language very early on that can cause people to think very, very binary about the information that they're receiving. Good, bad, this person is on this side, that person on that side. If you remember early on, a lot of the sentiments that were emerging from the headlines were very, very xenophobic because of where the virus had emerged in East Asia. So it became very clear to me that we were already entering this infodemic. And so one of the priorities of COVID Tracking Project was to make sure that what we were saying was apolitical, was true to the science, true to the data, and helped people, instead of responding in an emotional way, and instead of treating them as though they can't understand and dumbing things down, we wanted to elevate people's science and data literacy while also including cultural competence in that process. So one of the ways we did that was we made it very much a priority that we compiled data from official public, state, and territorial sources. And we did this all by hand. It was not machine automated, and which made us very intimately familiar with the data. We provided very, very specific annotations and markings on whether definitions were different or if they changed, and especially on anomalies. One of the things about communicating data is understanding caveats, disclaimers, warnings, and special notes, because at face value, data doesn't exist on its own, right? Data is created by humans who are interpreting information. And you want to make sure that that interpretation is accurate, which is why it requires more than just numbers and lines. So we had a couple trackers within our tracker. One of them that we were most known for was the race and ethnicity tracker. This was in partnership with the Center for Anti-Racist Research at Boston University with the leadership of Dr. Ibram Kendi. What we were doing there was trying to gather the most complete and up-to-date race and ethnicity data on COVID in the United States. Now, this is the understatement of the year, but we knew even before this tracker existed that Black and Brown communities were suffering more from this pandemic for a plethora of reasons. Those of us in public health have known that the underlying condition of this country, beyond underlying physical conditions of individuals, is racism, structural racism that has permeated public health and even medicine, that make outcomes for things like respiratory viruses or any virus for that matter, much more burdensome on communities of color who are less protected and less cared for by our healthcare systems. Now, unfortunately, this data was full of gaps, full of irregularities, and full of inconsistencies because it was relying on a very old and outdated system provided by the US Census. And I'll give a personal example of how I, as an Egyptian woman, have never been properly represented by the US Census. As an Egyptian woman, I am categorized as white. I do not identify as white, nor am I white. But because of the way that it is described in the parentheses, I would be on this demographic data considered a white person. Now, we are dealing with categories that have never been granular enough, specific enough to represent this. So even the categories that we had, which were sometimes as simple as Black, Hispanic, which really just means speaking Spanish, Asian, which is enormously broad, white, and indigenous, sometimes that's all we were working with. And sometimes we weren't even working with that. And so it became very difficult to create truly rich data understanding from this. But at face value, what we were getting was that Black and Brown people were dying at a rate of about 2.5x compared to their white neighbors. And that kind of kept us continuing to try to push states, especially state dashboards, to have better and more rich data that was representative so that people and community leaders and policymakers could make very specific decisions. Now, we also had a tracker on long-term care facilities. Long-term care facilities is a very interesting topic because it's such a marginalized community. Long-term care facility residents represent about 1% of the United States population, but almost 40% of the reported COVID deaths in this country. And it includes not just geriatric care, it includes rehabilitation centers. It includes places for people who struggle with addiction, places with people who are in transition from healthcare to being outside of any sort of medical facility. And because of the congregate living settings, it made it very, very difficult to experience these almost outbreaks within the outbreak. And they suffered at a horrible rate compared to the rest of the population. And the data about it was also really difficult to understand. So we had a lot of best practices to make sure how we were writing about this messy and unruly data was accessible and could be replicated by other people. One of those things was prioritizing clarity. So we wanted to use very clear language about what we were talking about. We wanted to build that trust through transparency by saying what we were doing with the data and what we were not. We were very clear that we were not modeling. We wanted to use very inclusive language so that we were not excluding people from understanding what this data and who this data represents. We wanted to use very specific time series to understand the context of what was happening, if this was real time or as close to real time data as we could provide. We wanted to have accessibility be a priority in all of our things too. So in everything from our blog to our charts to our tweets, alt text was always included. And the reason why we did that was because we didn't want anybody, regardless of their ability, to not be able to extract the information from these charts. So it was everything from making pages lean and very, very performant with low-end devices, regardless of the type of connection or the type of device you were accessing it. None of the kind of super fancy hover over things that would cloud information. So no hover effects, and making sure that if people needed more time with the data, that it was all downloadable for free via CSV files. So we had a number of very kind of known public outputs in our data visualization. In our data visualization, we know, and there's a book that I highly recommend called How Charts Lie, that charts at face value need a lot of explanation, especially because they have been used to tell stories that can be very, very difficult to understand, especially when it comes to demographic data. A lot of times it kind of can have an undertone of xenophobia even in that data, or exclusion in that data. So in all the things that we touched, in all of the outputs that we had, we wanted to make sure that we were prioritizing every type of person from every type of background and make sure that they were able to understand it and not be otherized or feel shamed by that information, or even shamed for not understanding that information. Now, I will say too that sentiments of things like mistreatment, undertreatment, and even abuse were very well documented prior to COVID-19. And I know that all of you are familiar with some of the historical things that have happened to Black and Brown communities that have made even approaching communicating about this pandemic and solutions to this pandemic, specifically vaccines, something that was going to be a challenge from day one. And I'm talking specifically about Henrietta Lacks and Tuskegee and the gynecological experimentation on Black and Brown bodies and maternal and fetal mortality rates in this country, and the general representation of communities of color in the scientific process, from bench to data science to clinical trial participation. These were all things on our minds as we knew what this next phase of the pandemic would be after we were just collecting the data. We knew that vaccines were coming. We knew that public health mitigation was going to come. We knew that our data was also telling people that since the beginning of this pandemic, we have never tested enough. And we were seeing that also show when we did a section of our research on county level data to see if there could be applications of this understanding on a more community-based level. And testing facilities continued to pop up more in white zip codes compared to zip codes that had predominantly brown population. So everything from the data applying to testing facilities to the data being a way to prepare for people's trust in the next phase, which was how do we get out of this, was on our minds and how we communicated. Now, there are no magic words that can build trust or erase the centuries of neglect and abuse on Black and Indigenous and Brown people. And oftentimes that focus, better yet, the burden of building that trust is placed on those communities that are already suffering the most. A lot of times when we talk about trust, we don't think about it like the social determinant of health that it is. And instead of treating it like the social determinant of health, we put it as an additional burden on communities of color to change their behavior against a system that is already kind of proven to be not trustworthy. So it would be wrong, as well as ineffective, to ask Black communities, ask Brown communities to just be more trusting. Instead, that responsibility needs to be on those who are creating the data, those who are designing the clinical trials, those who are communicating the data, and those who are actually applying these things, whether it's testing and vaccines, to become more worthy of trust. So how does that happen? How do we earn and deserve and maintain the trust of those who have been hurt by the system? The whole issue of trustworthiness is really about who delivers the message, what the message is, and who is receiving that message. It's this perfect triad, really, of these concepts in the message. And we have to be very, very community-based in terms of who that is, who these trusted brokers are of this information. How do we make sure that it turns into actionable steps for every person who is receiving this message? So in the context of the clinical research, let's say vaccines in particular, messengers like Dr. Kizzmekia Corbett created an enormous confidence dynamic in the early stages of research in the clinical trials. For me, as a science communicator, it was extremely important to amplify the voice of people like Dr. Kizzmekia Corbett, who was involved in the process of that data collection, of that understanding of how we're going to get through this next phase, and of communicating how we're going to get through that next phase. Now, in the early stages of the trials, the percentage of non-white participants was not great. By the time we got to about phase 3 trials, it was about 40% participants that were non-white for Pfizer and Moderna, which historically was a lot better than what we have seen. Now, how was that achieved? It was achieved through a few things, but I want to recognize those achievements, and I also want to recognize how much more we still have to do. Now, one, there has been a lot of work in the informed consent process to ensure maximum transparency. We want to recognize that that is a big milestone, because informed consent is something that is very important in the process of clinical care, and it continues to be a challenge in a lot of places. I will say the National Academy of Sciences too has recommended that people who are of a greater disadvantage of whatever the issue is, and in this case, like COVID-19, should be priority groups in receiving these solutions and treatments, and in this case, vaccines. And third, because we have lived through one of the most politicized seasons of science, a number of the companies had made it very, very clear that in the process, with the intention of earning the most trust, there was a commitment that they all signed. I think it was 9 companies that signed this Stand with Science commitment, that they would not submit vaccines for approval until it had been thoroughly vetted for efficacy and safety. Now, because of how we responded to this pandemic through Operation Warp Speed and the development of vaccines, we spent billions with a B of dollars to make this process happen. The FDA made it very clear early on that in order to continue to maintain this trust, because it was a fast process, that they would not even consider any of this data unless they had 8 weeks of post-vaccination safety data before it was reviewed. Now, that message was incredibly meaningful to me as a science communicator, but I couldn't find it anywhere. I couldn't find it in the main headlines about Operation Warp Speed, a terribly named and not named by a science communicator initiative. But that piece of information was lacking for way too long, that it caused the message and the mental image of warp speed to lead the way in early understanding of what was happening with the vaccine. Now, this is where I get very fired up about this, because we spent, like I said, billions of dollars to create Operation Warp Speed, and we didn't spend a dime on a communications plan to go in tandem with that. And this is part of the constant thinking of science communication as an afterthought. This is why I think that the work of COVID Tracking Project was so impactful, because it was one of our first thoughts, that science isn't finished until it's communicated, that science needs to be accessible to everybody, and that this data belongs to the people. Operation Warp Speed, the prioritization of how we do the science communication was not a priority to the US government, unfortunately. And it's taken this mess of the infodemic to then finally get the Surgeon General most recently to identify the actual devastating harm of not prioritizing science communication, and including people who are diverse members of the population to be part of that message distribution. Now, because policies are created by policymakers, again, they are only trusted and applied and well if they are communicated well. And we know that in order to make sure that there aren't any consequences for this issue of not valuing trust as a social determinant of health, we need to make sure that the policymakers and the policy communicators are not just diverse, but they are actually in different parts of our community, right? What I mean by that is the effort would need to be very firmly grounded in grassroots movements that would involve organization leaders, clergy people, faith leaders, elected representatives, community advocates, etc., that would be part of the message amplification. It seems very simple, but it goes a very, very long way, because a lot of times what we were seeing, and what it's similar to what I was witnessing many years ago in graduate school, was the silo effect. There was the science and the scientists, and then it was many, 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 many gaps in between the average person getting that information. But if Operation Warp Speed had a project or a tandem organization that activated these community leaders, it could have actually changed the earliest stages of building that trust and maintaining that trust, and also making it so that the trust work was on the responsibility of those who were creating the policies and the scientists behind it. So I was working with a group that was actually trying very specifically to target one demographic, because there was enough research to show that in sexual health advocacy, activating barbershop owners was very, very meaningful in what it meant to spreading really good information to the community about sexual and reproductive health. That was an amazing opportunity that we just missed early on. And it could have been done if the states were prepared for not only handling the data drama of COVID-19 in general, but what the next steps process, how we were going to get out of this pandemic. So trustworthiness is achieved when people develop these very equitable relationships. And these relationships shouldn't just come out of nowhere. They should have pre-existing clout. They should have pre-existing intimacy with those people that are sending and receiving that message. Now, one of the things that I feel like I have prioritized and kind of made my brand in science communication is knowing that even though science and science communication can be very difficult to understand and can trigger a lot of emotions, science communication without empathy is pretty meaningless. I would argue that there are very few things as destabilizing and disorienting and frightening as a global pandemic. I would say that it's more disruptive than things like war, and more disruptive than things like elections gone bad. A global pandemic involving a pathogen can affect anybody who is a human. And we have just now lived in this, and are still living through this pandemic that is affecting every single person. And yet we are not recognizing the fact that we are still speaking in a way that leads with emotion that causes further separation. Now, I think that there is a type of science communication that we need to recognize as not always effective in the context of things like social media, which is using language that is mocking, using language that is intended to otherize, and especially using language that is not inclusive. And I'm talking about inclusivity of abilities and inclusivity of race and ethnicity. So much of what we saw from the very beginning is still happening now, because people are defaulting to speaking about the vaccines and the virus and our responses to the virus in ways that put people on different teams. And I think that that is something that we are going to have to continue to resolve, because at this point, the trust that has been further broken is going to take many, many years to repair. And I think that there's an amazing opportunity right now for those who are science communicators to step up to maintain the trust that has been earned and to reestablish the trust that has been broken, especially when it comes to not having people who look like them as parts of those messengers. There's this quote from Albert Schweitzer that the only way out of today's misery is for people to become worthy of each other's trust. And I've explained ways that we can do that. But I want to give some more like tactical applications of how we can do that. So like I mentioned at COVID Tracking Project, we focused on things like accessibility from the actual, texts, and making sure that it was very accessible to all people. We need messages to be in all languages, in all formats, written, spoken, with different literacy levels, but they also need to be steeped in the cultural competence and emotional and empathetic language that is often lacking from science. A lot of trainees and a lot of people who work in clinical research have never taken a science communication class. I would argue that none of my technical training as a student was to prepare me to be a science communicator. It was the work that I did at Georgetown that created that skill set in me. And now looking back, I can think of many, many opportunities in my time as a student where learning the skills that I know now about how to translate, how to include, how to not otherize, and how to be effective in my communication could have made me an even better student and probably even a better science communicator than I am today. Now, one of the areas about vaccination trust and building trust that we still need to work on right now is addressing the folks who are undocumented and those who feel insecure in this country, including indigenous populations. We know that there has been a history of the government abusing data, abusing information about these populations to further act in harsh response to these people, whether it's through deportation, whether it's through incarceration, or whether it's through refusal of care because of a lack of health insurance. This is one of the ways that I think that the US government continues to fail in its ability to communicate things like the vaccine doesn't require citizenship status. The vaccine doesn't require even having health insurance. These are all parts of the science communication process that get left as the bits and pieces that folks like myself and others who know this process have to include in things, in all of the messages. So it's not just translating how an mRNA vaccine works. It's translating how the mRNA vaccine was developed, why it's a trustworthy process, what the application is of this research, and how the policies can actually protect each and every person. When somebody reads a headline or reads a policy about how a vaccine rollout is going to be, the first thing you think about is yourself. How does this apply to me? How can I be part of this process? And for too long, and for reasons that are not actually related to availability, accessibility continues to be a challenge for science communication. And accessibility, I had the honor of doing this outreach with helping people get physical transportation to vaccination sites because we're still dealing with a number of people who don't have paid time off, who don't have transportation, who don't have childcare to give them the access to these free resources that are so openly spoken about. This is the kind of afterthought consequence that I was talking about earlier, when we're not actually prioritizing the totality, the whole last mile process of the vaccine. I've said this many times that vaccines don't save lives, vaccinations do. But in order to get a vaccine to turn into a vaccination, trust through science communication has to be the pavement for that road. I feel like I could talk for much, much longer, and I'm being mindful of time. So I want to pause here and see if this is the right time to stop and we can go into Q&A.
Yes, hi Jessica. Thank you. I loved everything that you just said. I have a few questions, and I know there are some questions coming in from the audience. So yeah, maybe we can stop here, and hopefully you'll have an opportunity to share those additional thoughts you might have,
Okay.
if that sounds good to you.
Yeah, that sounds great. Okay,
awesome. And for everyone in the audience, remember to like and share everything that you're hearing right now. You can use the hashtag ISCS21, and also please add your questions to the comments through whatever platform you're watching us on. Okay, so the first question is from me. And so I loved what you said, which I hadn't thought about it this way, about trust as a social determinant of health.
Mm-hmm.
And earlier on in your talk, you also talked about the importance of understanding and communicating caveats and interpretations of science, right?
Yes.
So how do you go about communicating that uncertainty without diminishing trust in science and the process?
Yes. I love this question because I think that when you think about data, when you think about data visualization, a lot of people assume that you have to be very smart or even a data scientist to understand what that means. And I feel very strongly that that's not the case. In many cases, especially when you're dealing with bad actors who deliberately cause misinformation and disinformation to spread, they use these assets to cause confusion, right? So this is an opportunity to recognize, one, this is a very fear-inducing and disorienting and scary time. But let me walk you through this, right? So I'm going to give a very specific example. Early in the pandemic, there was this misinformation trend that went viral that was claiming that only 6% of deaths that were reported to the CDC were actually caused by COVID-19. And this was actually based on a chart that was on the CDC website that didn't have the proper legends and labels and disclaimers to actually explain the visualization. And if you actually read the chart and you understood what the chart was trying to communicate, the chart was actually saying 100% of these deaths are related to COVID-19. 6% of them only had one field entered on the death certificate, meaning, and it should actually tell you the opposite sentiment. The sentiment should actually be, this is actually really frightening. Even the healthiest people can die just of COVID-19 and not COVID-19 exacerbating other conditions or causing a cascade of other consequences. So this is the power of things like legends and keys and, text underneath a chart that says, hey, let me make sure that this picture totally makes sense. Our data visualization was, in my opinion, so over communicated because we wanted to make sure that if you saw anything, whether it was a different color, whether it was an arrow, whether it was a circle, that we were explaining to you where your eyes should go, what information you should be extracting from this, how it should make you feel. And so I think that when it comes to trust in that way and making sure that it's a, value in understanding people's reading of charts, you have to make sure that if you are putting something out there, there's a sense of responsibility in publishing data, that anybody who takes it from any corner of the internet will not turn it into something that it's not. And there is a great deal of responsibility in that.
Yeah, I completely agree. And what you just said actually segues really nicely into my next question, which is about how your communication approaches changed over time, right? So as you were getting more data and you were starting to notice that a particular subsets of the population were more affected by COVID-19 or maybe were receiving fewer vaccinations, how did your communication strategies change for the project as the pandemic went on?
They did, and they had to, because at face value, when you hear things like Black and brown people are dying more of COVID-19 than white people, people's assumptions are, well, is there something about them that are making them die? Is it their genetic makeup? Is it because of their race and ethnicity? And that's an opportunity to, again, take a step deeper into the science, take a step deeper into the public health and say, actually, this is a consequence of the other underlying condition in this United States, which is systemic racism, that the outcomes of these people are expected to be worse because of things like access, things like trust, things like abuse, things like neglect, and all of these things that are often missing from charts and from numbers and from data visualization. So it's an opportunity to kind of go deeper into that analysis and say, it's not just because these people are of a different race and ethnicity. These are the layers and layers of this research that are missing from that kind of explanation. And even using language like racism is a public health issue went a long way in helping my, viewers and my listeners understand that what I was talking about was not simply demographic data in the clinical sense. It was demographic data in the public health sense.
That's really, really important work. And similar, related to this and this idea of understanding which populations were more disproportionately impacted, we have a question from actually one of our co-organizers of the symposium, Lisette Torres-Gerald, and she asks, did you collect data on disability status disaggregated by race or ethnicity?
I wish, Lisette, and I love this question. We were so limited in the ability to actually disaggregate the data because it was based on census categories. And it was also based on the willingness of public health dashboards to include that granularity. So the problem of it was, from the very beginning, the federal government never provided data standards to the states. So we had 56 states and jurisdictions almost creating their own data definitions, their own dashboards that then we had to standardize and create trends that required, like I mentioned, so many caveats and disclaimers. We often bemoaned the fact that the data could have been so much more impactful, even for the next census, even for the next process of preparing for the next pandemic, if we had all kinds of representative metadata. I know the Biden administration, early before they were elected, said that they were going to commit to a tracker of all kinds of granular data that would include race, ethnicity, disability, et cetera. I've yet to see kind of how that's going to be applied because it requires a huge overhaul in our data metrics.
Yeah, and thank you, Lisette, for bringing this up. And I think it's so important for all of us when we're communicating to think about the fact that what you're communicating is also impacted by where the data comes from and like who's collecting it and what were they thinking when they were collecting that data. And hello to your little one in the background. Kind of going back to the question I asked a few seconds ago, I'm going to reframe it in a different way. I'm curious to hear more a little bit about your work personally as a science communicator on social media and how that work evolved over time through the pandemic.
So the work was kind of accidental in the sense that lots of my friends who knew my work in my research previously when I was in graduate school knew that I was kind of this nerd obsessed with emerging pandemics. And I would always say a pandemic of a respiratory virus was a matter of time. It was not clairvoyance. It was just because if you've been in my space, you knew it was a matter of time, not if, but when. So I kept getting bombarded with text messages and DMs and emails from friends saying, is this really happening? Is this what you've been talking about? So I thought, I'll just do some Instagram stories. This was back in March of last year, to kind of answer some general questions, some common questions from my friends. And it has turned into a whole thing. I'm really sorry.
Don't worry, this is reality now.
So it was, I did not realize that there was such an insatiable and captive audience on Instagram, but it has become a very rewarding process of trying to figure out exactly how to respond to these questions in a way that is not adding to the chaos of social media, but actually causing people to feel like, okay, this is calming, this is recalibrating, this is informative. And because a lot of times people's relationships with social media is harmful. And I wanted to create a place that was safe, a place that was judgment-free, a place where people could actually come, get a 15-second frame in a story and really understand it. So I've gotten really good at the 14.5-second answer to questions.
Yeah, I follow you. You're really good at that. We have another question from Sunshine, and I'm improvising a little now. Have you found a particular platform or venue more effective in your personal communication efforts?
Such a good question. I'm biased, and I have to say Instagram, just because it's very responsive. I have also created this very call and response relationship with my followers, in that for about 40 consecutive weeks throughout the pandemic, I was doing a Q&A every single weekend where I would solicit questions on Fridays and answered between 50 to 70 questions on Saturdays and Sundays. That cadence is not as aggressive anymore, but I continue to do it because I know that it's created relationships with people who I don't know, who then look to me as, a lot of people joke about, I'm like, people refer to me in their dinner parties at home, and that I'm like their, local epidemiologist or epidemiologist phone a friend. And so I think that that's been a very effective medium for me. I find Twitter to be a little bit more of an echo chamber and less call and response than Instagram, but I also think that that's just where I've dedicated the most of my time.
Yeah, I'm partial to Instagram as well for the for the reasons you listed. And right now it's a good time to remind everyone again to just post your questions in the comments in whatever platform you're watching, and we have plenty of time to ask Jessica her thoughts. I'm going to ask you the last of my questions before we get to other people's. And so earlier you talked about empathy and how empathy is crucial in doing this work. But empathy also means that it can take a pretty big toll on you as a communicator. And somehow, like you said, talking about vaccines has become an issue of pitting sides. And I noticed even yesterday in your stories, you were talking about getting threats and things of that nature. So I was curious about the strategies that you use to care for your mental health and well-being.
Yeah. Bringing that up actually makes me a little emotional because I think sometimes I am perceived as this like really tough cookie and I've got super thick skin, and I'm not. I'm like a super sensitive, emotional person. And, the vitriol that the scientific community has faced through this has been unprecedented. I think unprecedented has become kind of a word that gets tossed around, but I mean this quite literally in this context because it's not lost on me that I am a woman of color in my work, because that is something that is thrown at me constantly in my attacks. I have been the recipient of death threats, racial slurs, threats against my family, wishes harm, for me and my loved ones, attacks on my character, attacks on my faith, attacks on my work and integrity. And it's very easy to just plow through that and not hold space for empathy and care for myself. And I think that even the work that we did at COVID Tracking Project took such an emotional toll on us because, at the end of the day, it's not just numbers and spreadsheets, it's humans that we were counting, humans who were dying, the numbers were so hyperbolic at times that we thought, how can this even be real? It's so overwhelming, that the loss. So it's the gravity of the data, then the gravity of the people who were so committed to be against the work. It's caused me to really prioritize my mental health and setting boundaries. That means everything from limiting the accessibility that people have to me via DM, limiting my time on social media. I've had to take a step back because it's taken too much out of me. Seeing a counselor, seeing a therapist, and spending time with my family. I've had 2 young kids this whole pandemic, very young kids, who you can hear right now. And I think that they have actually helped my healing process. Yes, 1 second, buddy. By, taking me from, the density and intensity of this work and asking me to do things like explore dinosaur eggs in the backyard. And that kind of balance has helped help my brain healing from all of this stuff.
Yeah, thank you. Thank you for giving us those very actionable strategies. And so this will be our last question before we wrap up. Are there other science communicators who you think are doing an especially good job in terms of culturally responsive communication?
Yes. And I'm going to amplify the voices of a number of women of color in particular. I think Dr. Kizmikia Corbett is an incredibly effective science communicator. Dr. Wendy Goodall is an OBGYN in Chicago. She does incredible work in dispelling myths about fertility and pregnancy related to COVID-19 and vaccination. Dr. Uche Blackstock as well is an incredibly powerful science communicator as well, and physician. Dr. Darian Sutton. I'm happy to share actually names if you want to share with this community too. But I have been so committed to amplifying the voices of my colleagues and other people of color, because I think that, again, the messenger, the message, and the people receiving the message is the triad we have to always be thinking about when we talk about science.
Thank you. And that we'll leave it at that, because that's a really powerful way to end. We want to thank you for being with us today and for taking away precious time from your Saturday with your family. And so to everyone, thank you for joining us. We're going to take now a 15-minute break. I think our next session should start at 2:30. And so thank you for joining us, and we hope to see you throughout the rest of today's programming.